Welcome to a CME podcast episode from NEI, the Neuroscience Education Institute, hosted by Dr. Andrew Cutler. For complete CME information, please refer to this podcast's description page or go to nei.global/podcast.
Hello and welcome to another NEI podcast. And today we have a very exciting topic, especially considering something that happened approximately 2 weeks ago on September 26th. And with me is my good friend and expert in psychopharmacology, Dr. Jonathan Meyer. How are you, Jonathan?
Hi, Andy. Wonderful to be here. And this is an exciting time and an exciting topic.
Could not agree more. We're talking about muscarinic agonists and how they can work for schizophrenia. So let's get started, shall we? I understand, Jonathan, that this idea is not new of using these drugs.
Well, let's put it this way. There was somebody way back in the 50s, his name was Pfeiffer, who thought that this might be an appropriate way to treat schizophrenia, did some research with a compound called iricoline, which is one of the active ingredients in betel nut, did laboratory studies with animals, and then he gave it to some individuals with schizophrenia, and he noted in a 1957 paper that these individuals developed what he called lucid intervals. Unfortunately, there were other things going on in the world of schizophrenia in 1957, and the whole phenothiazine mechanism in its relationship to dopamine predominated, and really his ideas died on the vine and were not resurrected until a fortuitous discovery, which we'll talk about in the 1990s, which made people think again about targeting muscarinic agents, specifically agonists for the treatment of schizophrenia.
So there was a medicine discovered back then that was shown, if you will, to help schizophrenia. I wonder about the tolerability, though, and maybe that's why the chlorpromazine predominated.
It didn't seem to have tolerability issues. I think no one knew what to do with it. And then we had just the predominant paradigm, which Arvid Carlson won the Nobel Prize for, when he unified the idea that Parkinson's disease motor symptoms are due to a deficiency of dopamine. These new agents, although nobody knew how they worked, caused drug-induced Parkinsonism. And he put two and two together and said, hey, they need dopamine, and that's the paradigm. And all the animal assays that were developed since then, and which we continue to use, were really based upon what we're doing in terms of blocking dopamine, blocking amphetamine-induced hyperlocomotion, induced catalepsy, and things of that sort.
Right, and this, of course, led to the famous dopamine receptor theory of schizophrenia, which I did my basic research training in. And so this is partly why our medicines for the past, 70 years or so have been essentially D2 receptor blockers to try to block this hyperactivity of dopamine. But I understand, though, as time went on, we did start to get some research and some evidence that maybe acetylcholine muscarinic receptors might be related somehow to schizophrenia. Maybe you could talk a little about that.
Really, what solidified the whole concept was a fortuitous discovery that a muscarinic agonist developed to treat Alzheimer's disease, cognitive deficits, also had antipsychotic properties. So this compound, which I'll just tell you now is called xanomeline, was developed to make cognitive dysfunction better. And they found in these trials that people who took the highest dose in particular not only had some improvements in cognition, but also exhibited less delusions, less agitation, and there was no idea why. How can a drug which had no D2 binding at all, dominant paradigm, have antipsychotic properties? And this really set people on the path of looking at muscarinic receptors and schizophrenia.
I see.
And a lot of that research really found that, in fact, there are polymorphisms in certain muscarinic receptors associated with symptoms of schizophrenia, both positive symptoms as well as cognitive deficits. And we get into this later on, M1 expression in particular, most people's schizophrenia is below normal. But there's a huge chunk of folks, about 25%, who have what's called the muscarinic receptor deficit syndrome with really low M1 expression, more 75% or more below normal. And that contributes to both cognitive deficits and negative symptoms. But all of this was really driven post hoc by people trying to unravel how a muscarinic agonist can work for psychosis, driving the hypothesis that if this has antipsychotic properties, then there must be a relationship between muscarinic receptor dysfunction and typical psychotic disorder, schizophrenia.
Yeah, so once again, a kind of a fortuitous discovery, as has happened with many of our, if not most of our medicines throughout schizophrenia history, yes, and throughout psychopharmacology, I would say.
Absolutely. I mean, look, what's ironic is that clozapine, whose full mechanism of action is still not completely understood, was approved on September 26th in 1989. And then 35 years later, we have another really revolution in psychopharmacology, xanomeline-trospium.
Right.
Both of which were discovered to have their properties fortuitously. Clozapine, when it was synthesized in the late 50s, had a tricyclic structure. People thought it might be an antidepressant.
Yes.
It did not possess a lot of D2 blockade. It didn't pass animal assays for antipsychotic activity. And it's only because some people in Germany in the 1960s started to give it to folks living with schizophrenia that they realized it's possible.
Wow, incredible. So really the nodal points here are the mid-1950s, 1989, and now 2024. Those are sort of the three phases of psychopharmacology.
Really? I think you could say we really are in the next phase of psychopharmacology of schizophrenia, and we'll get into, really, the sake of the audience, the nitty-gritty about how these things work.
Yes.
How they can make symptoms of schizophrenia better.
Yeah. Well, if I could go back to xanomeline for a minute, I'm really intrigued, Jonathan, by this link you've talked about of cognition. So the initial thing here was they knew about M1, and of course M1 agonism was thought to help cognition. We know that anticholinergic medications are well known to impair cognition, cause delirium. So I see the logic. And as a matter of fact, if my understanding is correct, Jonathan, that first study that Lilly did in Alzheimer's was positive on the primary measure, the ADAS-Cog. Not a huge signal, but it was positive. But the signal, as you mentioned, was so much stronger for the psychiatric symptoms, particularly psychotic symptoms.
Yeah, the problem, of course, was that they gave this drug to these older people with dementia without titration, and at the highest dose, which was 225, it was very poorly tolerated. I think 12.5% of people actually had syncope. I mean, it was just very poorly tolerated. But some people thought it had potential, and there was a small pilot study done in 2008 with xanomeline. They did titrate it. They did go up to the highest dose of 75 milligrams 3 times a day. And even with a tiny study, 10 people on drug, 10 people on placebo, very low statistical power.
Yeah.
Drug still separated from placebo. But
this was schizophrenia. This one was schizophrenia.
That was schizophrenia. That was published in the American Journal of Psychiatry, 2008.
Right.
But the problem was,
again,
nausea and vomiting.
Procholinergic gastrointestinal side effects. Now, why is that, Jonathan?
Well, the price you pay for having a muscarinic agonist is it does its muscarinic agonist things in all sorts of the body. And xanomeline, it turned out, was synthesized as an M1 agonist, but it turned out to have even higher intrinsic activity at M4. We think the hypothesis is that the M1 activity actually drives a lot of the procholinergic adverse effects, nausea, vomiting, and diarrhea.
Yeah, and it has it binds to all 5 muscarinic receptors, but the intrinsic activity, agonism's highest, as you said, for M1 and M4, but there still could be some agonism as well at M2 and M3 in particular.
It's very weak. It's really highly selective in terms of its activity. Now, AI values, or all over the place. But the intrinsic activity is extremely high in M1-4, not so much for the other subtypes.
Yeah. So importantly, then, it's not selective. It is hitting the brain, the CNS, and the body. And that really was the issue. And my understanding is even the patients with schizophrenia, who generally tolerate medicines better, had a lot of trouble tolerating this medication.
Right. And people had to really solve the problem of how do you mitigate the procholinergic peripheral adverse effects. And maybe we'll get into that a little bit later. But the fact that xanomeline is paired with another medicine, trospium, was a result of that whole line of investigation is to try to find a way to mitigate the procholinergic adverse effects of xanomeline.
Peripherally, right. So Lilly, I believe, actually shelved the medication, and it was sort of dusted off later, as you said, the idea of resurrecting it somehow.
Yeah, that was it. And really what happened was during that intervening time, people did a lot of research on how these medicines, which are muscarinic agonists, might treat psychosis. Right. So let me give you maybe kind of a broad view, the 30,000-foot view of the positive symptoms of psychosis. If you, not you personally, but other people may have delusions or hallucinations, they have too much dopamine released in a certain part of the striatum.
Right.
Using the animal terminology, it's the mesolimbic pathway. In humans, it's a very similar process. It's just a slightly different part of the striatum. Right. Well, Andy, how do we manage too much presynaptic dopamine release? What was our strategy for all those years?
Unfortunately, it's been a postsynaptic strategy, binding D2 receptors, which unfortunately are found in many places in the brain. So there is what we call collateral damage.
That's it. I mean, that was it. But look, for some people that was helpful. But the primary problem we've come to understand from both animal studies and now human imaging is a presynaptic problem.
Yes.
Well, it turns out, and I'm going to use the animal terminology because people are familiar with it, that dopamine tract in the mesolimbic pathway, the VTA, which is releasing too much dopamine, it gets a couple of inputs. One of those inputs is a cholinergic pathway from the midbrain, and another is a glutamate pathway from the prefrontal cortex.
I see.
And it turns out that these muscarinic agonist agents or muscarinic receptor stimulating agents tune down those inputs into VTA, and therefore VTA just releases less dopamine.
Presynaptically,
and therefore we've shut off the flow of dopamine, which is what we always wanted to do.
Yes.
But we were really never able to do successfully.
Yes.
And that's the beauty of the whole thing. And the other exciting part is that these appear to be selective mechanisms within the brain, that we don't impinge on the motor system, we don't impinge on the pituitary. We're acting very selectively on inputs to the VTA. We reduce presynaptic dopamine release, and therefore we selectively treat the positive symptoms of schizophrenia.
So nature was very kind to us by putting these M1 and M4 receptors kind of where we want them to be for schizophrenia symptoms, but not where we don't, such as in the motor area, the tuberoinfundibular, prolactin, and so on.
Yeah, exactly. So let me give you a little bit of a sense of how this wiring works. And
before you do, Jonathan, let me say one thing that the audience might need to help us to link to something they already understand. So it's still dopamine, as you're saying, but acetylcholine has a special relationship with dopamine. I like to say it dances with dopamine. So if you raise acetylcholine, you are raising dopamine release in that system. And then the opposite, of course, would be what I want to do. If I lower acetylcholine, I'm lowering dopamine. So I kind of feel like that relationship is important for the audience. But then let's talk about the wiring and how it works.
Yeah, so as I mentioned, VTA, the dopamine tract, gets a cholinergic stimulus. And that cholinergic tract, which you may have never heard of, is called LDT. So LDT releases acetylcholine, it stimulates VTA, and therefore VTA releases more dopamine. Well, it turns out that LDT, that cholinergic pathway, has inhibitory autoreceptors. When you inhibitory autoreceptor just tunes down what is being released. And that autoreceptor turns out to be M4.
How interesting is that? Now, the LDT, of course, is an acetylcholine nucleus in the hindbrain, lower from the midbrain where the VTA sits. So this is sort of a bottom-up system. And then these autoreceptors, interestingly, are presynaptic on the acetylcholine neuron terminal.
Right.
See, and they're M4.
Oh, yeah. Right, exactly. On the end of LDT are these inhibitory autoreceptors.
Yeah.
Stimulate them. LDT releases less acetylcholine. VTA releases less dopamine. The animal, human, has less psychosis. But the The selectivity comes in. Again, this is just fortuitous. In the motor system, there's also another cholinergic pathway which stimulates those relevant dopamine tracks. And that cholinergic pathway, guess what, is controlled by M2 autoreceptor activity.
Isn't that fortuitous?
Very fortuitous. So we can decrease presynaptic dopamine release, which is what we always wanted to do. But most importantly, for everyone out there in TV land or radio land, we're doing it selectively. Yes. Therefore, we incur no motor side effects at all.
That's really incredible. So these presynaptic M4 autoreceptors, I kind of think of them as like a shutoff valve. You know, this is one of the brain's ways of regulating if there's maybe too much acetylcholine. It hits those and tells the neuron, hey, you know, tone down that acetylcholine. So then you have less drive of dopamine release. That's really elegant, Jonathan.
That's true in many systems. I don't know if you all out there know that, but D2 postsynaptic receptors have a counterpart presynaptically. So dopamine release neurons have synaptic autoreceptors, which are inhibitory, and they're a form of the D2 receptor. It's called the short variant. This is some many symptoms, and it's exactly as you explained it, Andy. It's a way of regulating the system if there's overstimulation to give you some feedback inhibition.
Yeah. Well, Jonathan, parenthetically, that's interesting you brought that up, because what a lot of people don't realize is when we are blocking these D2 receptors postsynaptically, we are also blocking those presynaptic dopamine autoreceptors, which is like taking your foot off the brake, and we get into a nuclear arms race of releasing more dopamine. And this is partly why historically we've been thought we've got to block 60, 80% or more of the postsynaptic D2s. And that, of course, causes problems.
Yeah, that was the issue. In case you all didn't know it out there, when you give a D2 antagonist, you actually disinhibit the presynaptic nerve. You cause more dopamine release.
Make it worse. Yeah.
As Andy said, you compensate for that by just blocking the heck out of things postsynaptically. And there was a sweet spot between 60 and 80%, but one thing, it's non-selective. There's a lot of collateral damage, and many people did not just tolerate the treatment.
Okay, so that is kind of the bottom-up M4 pathway. Mm-hmm. But you mentioned there is a top-down glutamate pathway.
Yeah, so as I said, VTA also gets stimulus from glutamate neurons. Those glutamate neurons originate in the prefrontal cortex. Mm-hmm. And those glutamate neurons have a brake on them, and that brake is what's called a GABAergic interneuron. It releases GABA, and GABA is inhibitory. It's a regulatory system on glutamate release.
Right.
Well, guess what? Those GABAergic interneurons have M1 receptors on them.
Oh, my.
M1 receptors are stimulating. And so what we're doing is actually stimulating the interneuron, but that interneuron's function is to be inhibitory.
Wow, that's confusing.
Yeah, we're stimulating the brake to be a more effective brake. We're throttling down, it that way, glutamate release.
Okay.
And therefore, VTA is less stimulated by glutamate, and VTA is releasing less dopamine. Again, presynaptic and selective in the brain.
Interesting. So the VTA can be stimulated either by acetylcholine or by glutamate, which, of course, glutamate we know is the excitatory neurotransmitter. So in a sense, you're stomping down harder on the brake of the glutamate. That's fascinating. And that glutamate neuron in the so-called, this pathway, I should say, does not synapses directly onto the VTA. And I think that's a little bit important because the wiring in the mesocortical pathway is slightly different when we get into cognition in a minute, perhaps.
Yeah, absolutely. And I think that's the whole point, is that this M1 and or M4 receptor stimulating strategy seems to act fairly selectively in terms of reducing presynaptic dopamine release where we want to and not integrate the brain where we don't. And that's always what we've wanted and we never have.
Yeah, incredible. And it's doing it a little more elegantly here presynaptically, which is kind of where the problem is. Now, Jonathan, another historical note, and I think you taught me this, the first drug actually FDA approved in America for schizophrenia was what?
Reserpine.
There it is. For those of you who can't see, Jonathan's holding up an actual bottle that says Reserpine alkaloid. It's one of the original bottles. And Reserpine, how did that work presynaptically?
So Reserpine was a VMAT inhibitor. It was non-selective, though. It was VMAT1 and VMAT2. At low doses, it inhibited VMAT1 in the periphery, and it became a very useful antihypertensive.
And that's how it was used, yes.
But people realize, hey, if we crank it up, we can actually get antipsychotic activity out of it because we're going to reduce presynaptic dopamine release, mostly by depleting the presynaptic nerve terminals of dopamine.
Right.
But problem, it was non-selective. It did it in the mesolimbic pathway. It did it in the motor pathway. And so at the point where you started to get antipsychotic activity in a number of people, you also had drug-induced Parkinsonism and akathisia. And unlike D2 blocking antipsychotics, there was no way to modulate that mechanism to make it better, make it more tolerable. People tried with tetrabenazine, and that line of research ended fairly quickly by 1963, and that was the end of that.
Right.
We figured out that if we dose D2 blockers lower, or with the second generations, we add on serotonin 2A, we can improve the motor tolerability.
Right.
There's no way to improve the tolerability for these non-selective VMAT2 inhibitors.
Yeah. And of course, also reserpine had a lot of trouble with orthostatic hypotension. That was what it ultimately was used for therapeutically. So wasn't as well. Yeah. But the point is, we did have an approved drug that was presynaptic, maybe not as well tolerated. So I'm just trying to get the audience to see this concept of working presynaptically is not entirely new. The concept of muscarinic agonism is not entirely new, although we understand it better now, I would say. And it sounds like, Jonathan, and there are preclinical models as well, that both M1 and M4 agonism may contribute to an antipsychotic effect.
Right. Yeah. Go ahead.
But there are drugs in development, of course, that are pure M4 either agonists or partial allosteric modulators. So it seems that M4 agonism by itself may also be antipsychotic.
Oh, there's no question. I mean, we've talked about just the wiring, but people have created animal models with M1 and M4 knockouts. They both show the phenotype of schizophrenia, both of which respond to stimulation of those respective receptors.
Yeah.
The big debate in the field is that we think there's some upside for M1, but in the periphery, there may be some price to pay. So what's the upside of M1? We'd already talked about one mechanism that contributes to positive symptom efficacy by working through that descending glutamate pathway and tuning it down. Right. But going back to something I mentioned earlier, most people with schizophrenia have diminished M1 expression, and 25% have really low M1 expression, meaning 75% or more below expected norms.
Right. And Jonathan, clinically, that correlates with what?
Cognitive deficits.
More cognitive, yeah.
And negative symptoms, too.
Ah, okay.
And there's actually a name for that subgroup. But again, that's about 1/4 of the schizophrenia population. It's called the muscarinic receptor deficit syndrome.
Okay.
And the punchline is, in the clinical trials of xanomeline-trospium, they had cognitive assessments, and they found those people who had really low baseline cognitive function saw a cognitive benefit from xanomeline. It wasn't everybody. So the point is that it may preferentially really help those people who have really, really low M1 expression. Now, these people weren't imaged, but the inference, I think, is quite clear that it wasn't everyone. It was the people who probably had really low M1 expression. So that's kind of a really nice bonus from the M1 property. And we think it's mostly M1 related, but there may be some M4.
Yeah.
But the downside, as we talked about, was the procholinergic adverse effects.
Yeah. So let's just take that one step further, because also in the clinical trials, there was a signal on negative symptoms. And granted, these were people loaded for positive symptoms, maybe not the best situation to look at that. But M1, there's a theoretical reason how it may help both negative symptoms and cognitions. Maybe you could talk about that a little.
Yeah, I think so. Again, negative symptoms, unlike positive symptoms, are much more diffuse in terms of the neurobiology. We can point to, unless you're treatment resistant, that for most people, the underlying problem of positive symptoms is too much presynaptic dopamine release in a specific tract. Negative symptoms involve a number of different areas of the brain, both prefrontal cortex, the reward pathway. So it's not quite as neat and simple. but the idea that perhaps some of these activities may also improve negative symptoms by working maybe in the prefrontal cortex or other areas has been seen in animal models. The xanomeline-trospium negative symptom data was just published online recently in the American Journal of Psychiatry. The first author is Horan, Horan. And that paper looked at the improvement in negative symptoms. In case most of you don't really appreciate this, if I make schizophrenia better, I make everything better. I mean, if you're acutely psychotic, I make everything better, positive symptoms and negative symptoms. But our best signal has always been for positive symptom improvement. And we often thought that if negative symptoms got better, it was just along for the ride. And the term for that, Andy, has been?
Secondary.
Secondary, or the fancy 50-word Roger McIntyre word is pseudospecificity.
Pseudospecificity, of course.
Right. That it's not a specific effect of haloperidol or risperidone. It's just I made everything better. So this person who was avoidant, which is one of the negative symptoms, well, they're not avoidant now because they're not paranoid.
Exactly.
But the Horan analysis tried to look at that, and they wanted to make the argument from their data that the improvements in negative symptoms across the pivotal trials did not seem to correlate with positive symptom improvement. Now, it wasn't a designated negative symptom study, so you have a little bit of a grain of salt, but I think it's something that's really interesting and exciting as a potential.
Right, and there are a couple of potential reasons for this. One is that, as I alluded to earlier, the mesocortical pathway, the descending glutamate neuron does not synapse directly on the dopamine neuron, the VTA. There is a little GABA interneuron interpolated. And so if I tone down glutamate drive, I am taking my foot off the brake and potentially increasing dopamine back up into the prefrontal cortex. That's a theory for negative symptoms and cognition. And then, of course, as you know, there's local microcircuits, local glutamate microcircuits in the prefrontal cortex that have M1 on them, and that may be part of the procognitive. So this is a lot of theory, but we'll see.
Yeah. So I think so the audience is like, okay, so how did they solve the...
Yeah, exactly. Yes. Let's get to that.
Because there may be a benefit from M1, and xanomeline was the only compound in existence for decades that was showing promise. And so what happened was some very smart people took this compound from Eli Lilly, they ported it over to a new company. They found an anticholinergic which has limited CNS penetration to pair with xanomeline. And now many of you have heard from myself, Andy, our good friend Les Syndrome, about the evils of cogentin. And
yes.
Really, and I'm going to say this straight up, that the use of medicines like cogentin and Benadryl is no longer accepted as standard of care because of their cognitive impairment.
Yes.
People with schizophrenia have a cognitive disorder. Why make it worse?
Sure.
Well, the other thing is xanomeline works by stimulating muscarinic receptors. If you added an anticholinergic, which got into the brain, it would interfere with its mechanism of action. And that's been shown in animal models using scopolamine. Beauty of trospium, which was a medicine approved in 2004 for overactive bladder in the U.S., is that it has very, very minuscule CNS penetration.
Yes. Whereas some of the other overactive bladder drugs did get into the brain. That was a problem. So,
they got in very strongly. What's the worst thing you could ever give to an older person with overactive bladder?
Oxybutynin.
You got it.
Tetrapan.
Yeah, and you want to make this person delirious. That's a good way to do it.
Good one. Yeah.
But trospium did not do that. It has very minuscule CNS penetration, and that's why it's paired with xanomeline. It reduced the rates of nausea and vomiting dramatically. But they're not absent, but dramatically, and allow this drug to proceed in development. But what other people have said, well, maybe we can get by with just an M4 only strategy.
Okay.
Couple of compounds out there which are in various stages of development.
Right.
The first one is emraclidine, which is a PAM. You want to tell people what a PAM is?
Well, sure. So when you're talking about receptors, you can bind to the same site as the endogenous ligand, or let's use acetylcholine. the site where acetylcholine binds. That's called the orthosteric site. But there is another site you could bind to on the receptor, which is called the allosteric site. And when you bind there, you change the conformation of the receptor, and you can make it either more likely to bind, more receptive, I would say, to the endogenous chemical acetylcholine, or less likely, make it harder to bind. So if you're enhancing the binding, that's a positive allosteric modulator, or a PAM, as Jonathan said. If you make it harder, it's a NAM, or negative allosteric modulator. But Jonathan, my understanding is what's interesting about these muscarinic receptors, M1 through M5, is that the orthosteric site, the endogenous site, is pretty conserved across M1 through M5, but that the allosteric site is a little more unique for each one of them, and that may allow you to target M4 without hitting the others.
Well, that was the idea for that one company had, and they came up with a compound called emraclidine.
Right.
As opposed to being an agonist, which binds, as Andy said, to the orthosteric site where acetylcholine normally binds. This binds to the allosteric site, and it's highly selective for M4. And guess what? They have some phase 1B data, which was published a couple of years ago. What didn't we see? Vomiting.
Right.
But again, it was a small study. The total sample size, I believe, was 81.
Mm-hmm.
And we're, kind of waiting with bated breath to see their later phase data, because the one thing that's really exciting about xanomeline-trospium was that the effect size across all their later phase studies was quite high. It was 0.65. And we haven't had a drug approved for schizophrenia with an effect size that large since olanzapine was approved on September 30th, 1996. And you know why I know that date, Andy?
I don't.
Because I have no life and I'm a loser.
No, I would say you have quite a life, Jonathan. I know that from personal experience, but you are a veritable font of knowledge, and this is helpful knowledge.
Some of which is useful. But the point is, that had a big effect size. And especially as placebo was eroded into drug placebo difference over the years, nothing has come even close. And in recent years, what's been some of the effect sizes in drugs approved in the last 10 years for schizophrenia?
Well, you're lucky if you get 0.3, 0.4, I would say. So higher effect size, of course, means a stronger signal, greater separation from placebo, potentially greater efficacy. But the fact, too, Jonathan, that the consistency between their phase 2, which is earlier data, and phase 3, which is your registration studies you got to do to get approved, was quite consistent. As you know, I've been doing trials for 30 years, and you almost never see the same kind of efficacy in phase 3 as you do in phase 2. You lose your signal as you ramp up and try it in more patients. But here, Jonathan, 3 studies, phase 2 and then 2 phase 3s, all had really high effect sizes.
What was remarkable was in the 2 phase 3 studies, the effect sizes were almost identical, 0.60 and 0.61. I mean, that's unbelievable. And these are numbers we have not seen in a long time. So the question before the audience, before the field of psychiatry is, will an M4 specific strategy give us effect sizes? Because as we know, in many ways, the practice of psychiatric medicine is sometimes a trade-off that people may be willing to trade off. If there is a trade-off in efficacy for improved tolerability, maybe we don't have to make that trade. We know emraclidine had improved tolerability, did not have the signal for procholinergic adverse effects to the extent for xanomeline, and we will see. I mean, that's really the big question out there for everybody. And we hope we'll see data, maybe the next 3 to 4 months?
Yeah, they're in phase 2 now, which again is right before phase 3. So phase 2 is positive. They will have to do phase 3 program. So this drug is, Jonathan, still a couple of years away. But the real question here is, how important is M1, as you've mentioned? How effective is a positive allosteric modulator versus a full agonist? And as a matter of fact, there are a number of these drugs in development, all with various combinations of M1, M4, agonism, positive allosteric modulation. There is another one that's a little further back that just reported out some positive data. This is from Neurocrine. This one is an M4 agonist. And Jonathan, it's interesting that the binding to the muscarinic receptors is very elegant. There's a lot of ways of playing around with that can get over that problem of selectivity. And there's something called bitopic binding. We don't have to get into all the details, but they have found a way to be an agonist and still be relatively selective. So what's also interesting, Jonathan, is this mechanism now across three different drugs is 6 for 6. If we look at the original xanomeline trial, the 3 Karuna KarXT trials, these emraclidine trial, and now this NBI 1117568 to be fancy, all of those are pretty positive. So we're pretty optimistic that this mechanism, to me, is very well validated, and it is very exciting, completely new generation of drugs.
Absolutely. And I think that's the whole point, is that we've now come to realize you don't need to bind to D2 to make the positive symptoms of schizophrenia better. And if we're lucky, we also get a bonus on negative and cognitive symptoms. So those are a couple of advantages. I think some of the other advantages have to do with other aspects of tolerability.
Okay.
I already outlined kind of the pharmacological rationale of why we don't expect motor adverse effects with these muscarinic selective agents. And across the 3 studies of xanomeline-trospium, did we see Parkinsonism or akathisia, Andy?
Really no signal versus placebo at all for drug-induced movement disorders.
And how much hyperprolactinemia did we see?
I would say bupkis or Z or 0, however you'd like to say it. There was none.
Yeah.
And again, we didn't predict it because M1 and M4 are just not in the tuberoinfundibular pathway.
And how much weight gain did we see on xanomeline-trospium?
Well, quite surprisingly, there was no signal for weight gain, either in shorter or longer-term trials, no metabolic dysregulation signal. Almost too good to be true. So I guess the price you pay, though, is a little bit of an interesting combination of peripheral pro- and anticholinergic side effects. And that may be a pharmacokinetic reason, Jonathan. It's pretty hard to completely match the blood level of both of these drugs, the pro and anticholinergic, at the same time. So there could be moments when one is predominating over the other. It could be some people are more sensitive to one or the other.
Yeah, I think one thing is that when you do registrational trials, you're stuck with a fixed titration.
Yes,
the standard xanomeline-trospium titration was, and the compound is always referred to by the dose of the xanomeline first and then the trospium component. And so it started as 50-20 for 3 days. Yeah. Then they went to 120 for the remainder of the week. And then they went to the highest dose, which had
125,
30.
125, 30, yeah.
Yeah, okay. So that was the fixed titration, and they got what they got. They couldn't change that. I have a feeling once it gets into the hands of clinicians, they will realize that for some people, they may wish to moderate this titration, perhaps out of concern, mostly for the procholinergic adverse effects. Constipation, I think we're pretty good about being able to treat. And
I agree.
That's maybe not the deal breaker that nausea or vomiting might be. Yeah. Once it's out into the hands of the public, I think people will realize there's ways to maybe adjust this. Yeah. Practically speaking, because of the titration, it often may not be used on acute inpatient settings, but I think the target will be out in the outpatient world. You have a lot of people who will need the efficacy with these effect sizes, and there also will be some who will be switching for tolerability, but there won't be quite the urgency that I got to crank this thing up immediately within 8 days. As on an inpatient unit, which gives you maybe more luxury of time to play with the titration to see how we can mitigate some of those issues. And there's also some unique things because of the trospium component. Again, trospium doesn't really get into your brain. That's why it was chosen. Right. But for some people, giving trospium may not only cause constipation, but certainly in older males, there's a risk of urinary retention. Yeah. Some cautionary language about that, and certainly cautionary language not about moderating the dose also for people above the age of 65, probably because they didn't study that population. They say, you might want to just limit this to 100/20 as the maximum dose.
Right. Well, what you said about dosing is interesting to me because it alludes back to something we said earlier. To get drugs approved for schizophrenia in the U.S., these studies have been done in acutely psychotic patients with a lot of positive symptoms that are hospitalized, so very acute setting. And yet, as we know, as you're saying, a lot of times these drugs are not used in that setting because of cost and access, partly for some reason, but other reasons. And so they're going to be more of an outpatient drug, and maybe it's a drug you're switching or you're adding on. And adding on actually here does make some sense. This is a little bit of rational polypharmacy. And so you're right that when you're doing an acute setting, of course, you're more aggressive with your dosing. You want to get efficacy as quickly as you can. But when you're in the outpatient setting, you can slow it down. And Jonathan, one of the amazing things here is the package insert recommended dosing. I haven't seen this very often in all my years. Usually, the recommended dosing is exactly how it was done in the clinical trial. And so you would think it would say 2 days go up, 5 days go up. It says 50-20 for at least 2 days, and then 120 for at least 5 days. What that says to me is you already have permission. It is on label to go slower with your titration. And as you've said, you probably will get better tolerability. And Jonathan, I predict in the real world that there might be better tolerability because of a slower titration. That would be wonderful.
Yeah, I think that makes a lot of sense. And I really want to encourage everyone to download the package insert for xanomeline-trospium. It has a trade name, just so you know it. It's called Cobenfy, Cobenfy. But there's some interesting stuff in there. So one thing that's interesting is the word antipsychotic does not appear anywhere in the package insert.
You're kidding. Wait a minute. Does this drug work for schizophrenia?
That's what the language says. This is an agent approved for the treatment of adults with schizophrenia.
Okay.
And we've kind of talked over the last couple of years that there's a revolution coming, and the revolution is now here. Well, I think the FDA really has reified that. There's another fancy word.
That's a good word.
With the idea that this is its own class, and it does not have many of the baggage or, more importantly, the language that we see in terms of warnings associated with the class that we've normally come to expect, particularly the black box warning. Are there any black boxes in this package insert?
No, which is highly unusual, again, in all the years that you and I have been seeing drugs come out. There's no bolded box warning for the increased mortality in elderly patients with dementia-related psychosis. And so it's fascinating, as you said, this drug is considered a different class. So it didn't get the baggage warning. He's also, Jonathan, to your point earlier about tolerability, does not have any of the drug-induced movement disorder warnings, no prolactin warning, no weight, metabolic, glucose, lipid warnings. Really surprising.
Yeah, just a weird thing. So a couple of contraindications are, don't give it to people who already have urinary retention, because it's going to make it worse, because what does trospium do? It's an overactive medicine. Don't give people who have gastroparesis, because they already have a GI motility problem and the anticholinergic aspects of trospium. But that's about it.
Well, Jonathan, interesting though, this drug inherited those warnings directly from the trospium package insert.
Right.
But we don't know what pairing it with a procholinergic drug. Xanomeline is peripherally active, so may not be as huge a deal, but I think it's wise to follow the package insert warnings.
Yeah, I think people have active urinary retention. You probably want to get it fixed. I'm just going to, I'm saying you have to insert the Foley at your office yourself.
No.
You want to make sure that's managed, because you potentially make it worse.
Yes.
Now, if they're on an OAB medicine, maybe you can just spit off of the trospium.
Right.
The issue of gastroparesis is not something we see a lot of. I don't see a lot of people with diabetes who are the predominant population with this problem. But, I don't know if you folks have heard out there, for those of you who maybe have been living on Mars in a cave under a rock, there's this class of medicines which works for obesity. And what's one of the side effects of the GLP-1s and their cousins?
Well, they can cause diarrhea or gastroparesis or constipation. A very strange GI, but certainly gastroparesis, right?
Yeah, most what we concerned about is slowing of GI motility.
Yeah, that's right.
And so I would just say, if you have someone who's already complaining of that problem, take it seriously. It doesn't mean you can't use this medication. It may be, as we've talked about for a lot of these things, the adverse effects will be managed by slower titration. And that's one way to get around some of the other comments in the package insert about our joint interaction with 2D6 as well. It doesn't mean you can't use it, just kind of go slowly. If you have somebody with cirrhosis, you can use this, but they have to be Child-Pugh A.
I see.
And it doesn't mean you can, it just says not recommended. Well, the point being is it's not a contraindication, but they're saying if you're Child-Pugh B or C, you cannot use this, but I don't see a whole lot of these people. They're trying.
Right.
Child-Pugh A, you may see, but just, be careful. Adjust the titration and monitor the patient appropriately.
Yeah, so it's contraindicated in moderate to severe hepatic impairment. It's funny, it's not recommended for mild, but it's not contraindicated, as you've said, so you can be careful there. There's, of course, the other warning, Jonathan, related to heart rate.
Yeah, there's a small measurable change in heart rate. I think it was 5.9 beats per minute. I think the idea is people are going to be coming in periodically. You can just check their heart rate. The only other thing which it's recommended to keep an eye on was LFTs. There was a transient bump. It was less than 2% of the study population. I want to say it was 1.2%, most of which had resolved at the end of the first month. And so the recommendation is have a baseline set of LFTs, which includes a bilirubin. And they're very vague, so I'll give it to you in a very straight thing. Since most of these people had resolved at a month, just recheck them a month later. For 98.8% of the human beings on xanomeline-trospium, there will be no change. If you see an abnormality, then perhaps you'll monitor it once more. And of course, if it gets way out of whack, 5 times upper limit of normal or 5 times baseline, then you would stop it. But then barring that, which is likely to be very uncommon, I think the point is that have a baseline and then just check it once after a month, and then, that usually will solve the problem there.
Right. Well, to your point, yes, people continued the medicine. They had these LFT elevations and they went away. But the package insert does recommend, Jonathan, getting LFTs at baseline, and then it says periodically, throughout treatment. But I think your guidance is wise. And for people who are saying, "Oh my gosh, I have to get LFTs," Jonathan, aren't we supposed to get blood work with all the other antipsychotics, the atypicals at least?
Yeah, unless the only lab you ever run on a human being was a lipid panel or an A1C, you likely have a chem panel somehow in the recent past, which could be used. Exactly. Yeah. So it doesn't mean it had to be yesterday. I think most people, especially for the sake of liver function tests, would say anything in the last 6 months is probably fully acceptable and valid. I want to make one other thing about hepatic dysfunction, just as my little soapbox here. When we're talking about hepatic dysfunction, in the language around hepatic dysfunction, what we're talking about is cirrhosis, not
problems with synthetic capacity, not just inflammation or
not inflammation at all.
Yes.
Right?
Yes,
because just because you have elevation of transaminases does not mean you cannot metabolize drugs. In fact, it has no impact on it. And the point being, that just because somebody's AST or ALT is abnormal because they drink or they have non-alcoholic fatty liver, that doesn't preclude them from using this. The most important thing is we're looking for people, when they say hepatic dysfunction, it's cirrhosis that interferes with your ability to metabolize drug.
Well said.
When people come in, if they have abnormal LFTs, almost always it's going to be inflammation. And you ask them, you have cirrhosis? They'll probably say no, add up their Child-Pugh points, and they'll be A. And then again, you can use the medication if they don't have cirrhosis normally. If they say, I do have cirrhosis.
Yeah, right.
Well, that's unfortunate.
Well, there's actually some ways to check that. You can look at albumin and you can look at coagulation indices, a coags we call them, because those things are synthesized by the liver. And so when you have problems there, then you've got problems with your metabolic properties of the liver. So that's another way to look.
Right, exactly. The 3 labs in the Child-Pugh scale are total bili, albumin, and INR. But just ask the person if they have cirrhosis. Most people know this.
Most people would know, yes.
You see abnormal LFTs, if they're just transaminase elevations, that's cirrhosis. That's a different problem. We're looking for people with cirrhosis.
Yeah. And Jonathan, you can see that too with people who take a lot of NSAIDs, acetaminophen or NSAIDs I've seen. So
I worked at the VA here in La Jolla for 15 years. I literally saw one individual with schizophrenia who was Child-Pugh B. And he had ascites, he had advanced cirrhosis.
Sure.
There were people who had Child-Pugh A. These were individuals who were either drinkers who actually at that time we had a lot of Hep C.
Yeah.
And they got cirrhosis, but they were Child-Pugh A. I could use this medication for them. I would just maybe moderate my titration.
Yeah. Jonathan, there's one other thing we need to mention. We got to go back to efficacy for just a second. We talked about how at endpoint and these trials were 5 weeks because the first week was considered titration and then 4 weeks of treatment, which is now kind of the standard for antipsychotics. But not only did it have the strong effect size at the endpoint, but it separated at the first time point measured, which was what, Jonathan?
It was week 2.
Week 2. So there was not, interestingly, they did not measure efficacy at week 1. The thinking was perhaps the dose was not quite therapeutic yet. Mm-hmm. So the first time point measured, week 2, it showed efficacy, which is also rather quick, I would say.
Yeah, there's no question that this medication works. It works well. Why would you not check a time point at week 1? Well, you have a titration. That's why. It's kind of self-evident. That's why it's a 5-week study as opposed to a 4-week study as been done throughout recently approved. And of course, they have open label data which go out to a year, show very similar signal about sustained response, as well as the absence of metabolic and endocrine adverse effects, the absence of order side effects.
No new safety signals even after taking it for a year. And interestingly, Jonathan, there was a trend towards weight loss over time. And perhaps this is a weight-neutral drug, and if people are taking other atypical antipsychotics and it gains some weight, I don't think we can definitively say this is a weight loss drug, but it appears to be at least a weight-neutral drug.
Yeah, I would never say the word weight-neutral because most of it, I'm just saying in terms of talking to patients.
That's right. Right.
The average age of most people in schizophrenia trials is around 40 years old.
Right.
And when you give medicines to 18-year-olds, sometimes you see things that you don't see in 20-year-old, especially with sensitivity to the weight gain. On the other hand, I would say this might be the closest we will have to it in that population that we've ever seen.
Yeah.
We just don't have enough of those people in the trials to make a definitive statement. But I would kind of bet, not that I have a gambling problem, but the bet that I do live a mile from the Del Mar racetrack, but they're not racing right now, not for a few weeks. Anyhow, but I would bet that actually in the first episode, younger people, 18 to 25, it may be weight neutral. I just don't have the data to back it up just yet.
Yes. I think the responsible thing is to say unlikely to cause weight gain or, minimal signal. All right, Jonathan, with the time we have left, I think we need to talk about some practical considerations, particularly for how this drug is likely to be used, as we said, which is more of an outpatient, either switch drug or add-on drug. And the first thing I want to start with, of course, you, Les, and I think Les is the most recent president of the I Hate Benztropine or I Hate Cogentin Club. What happens if you give this to somebody who is on an anticholinergic agent or perhaps an atypical antipsychotic with endogenous anticholinergic activity? What might happen there?
So, and I'm going to frame this question very specifically. What we're talking about out there is people who are on agents which have centrally acting anticholinergic properties. Because there's two things. You could be on a peripherally acting anticholinergic, and your concerns very specifically will be, I will be giving them more constipation,
safety and tolerability,
but peripheral urinary retention.
Right.
But if you're on a centrally acting anticholinergic like olanzapine, potentially high-dose quetiapine, and certainly benztropine
and clozapine,
hexafenadil, clozapine, chlorpromazine, diphenhydramine. The concern is that their anticholinergic properties in the brain will interfere with the xanomeline mechanism of action.
Yeah.
We've been, I think, railing and ranting about getting people off of benztropine and diphenhydramine. So I want to tell you all out there, you should try to chip away at this stuff now, because when the time comes when you want this person to get the benefit of xanomeline for efficacy in particular, they're not going to get it if they're on benztropine or diphenhydramine. So try to taper them off. If they really needed the benztropine for drug-induced Parkinsonism, what's the alternative to benztropine?
Well, interestingly, you can try amantadine.
That's my favorite choice, absolutely. Not anticholinergic, doesn't cause cognitive impairment. But to be honest, many people never needed it to begin with.
Right. That's true. Certainly long term. We know that drug-induced Parkinsonism can be managed through dose adjustment, switching to lower potency agents. Or
amantadine. If you don't want to switch, you're on an LAI, you don't want to switch. That's fine. You just but taper off the benztropine slowly. I think a usual taper is 0.5 milligrams every 2 weeks.
Oh, that's slow. Yeah.
It's slow, but if you go quickly, people might get rebound effects. And they're like, I told you I needed it because look how terrible I feel.
That's right. And what often happens then is the new medicine is blamed for that. And certainly my concern, Jonathan, we should address this, is because this is such a new mechanism, it's not D2, I've been steeped in dopamine, maybe it's not going to work as well. And so now if I use it with one of those agents and it really doesn't work that well, not because of the drug, but because of what I'm potentially undoing, the central mechanism, I'm afraid people will not get an accurate impression of this medicine.
Well, that's it. And because it does take a bit of time to get rid of benztropine, it's not like, I'll do it in the week where I'm titrating the xanomeline-trospium.
That's right.
Yeah, that's not enough time. That's not enough time. So you want to start chipping away at it now so that you benefit. Now, let's say you have an individual who's on olanzapine is going to switch for either efficacy or tolerability. That would be an instance where I could cross-taper it with the olanzapine over a week or two, maybe because you'll modify the titration, especially if they're on higher dose olanzapines. You can get rid of it a little more slowly. That's fine. For other antipsychotics, though, there's actually an adjunct study out there, and you want to
Interesting.
review for people what some of the agents are that are in the adjunct study.
It's basically atypicals other than olanzapine and quetiapine.
Right. Or clozapine for that matter, too.
No,
right.
clozapine, of course. Yeah, but
Exactly.
it's others.
Yeah. So the point is, if the underlying antipsychotic is not anticholinergics, they're on LAI aripiprazole, or they're on paliperidone, or risperidone, ziprasidone for the 5 people out there still on it, you could to that agent and even not even take away the original antipsychotic if you don't want to.
Well, I'm very excited, Jonathan. We don't have a lot of adjunctive trials like this, particularly in schizophrenia, and certainly not 2 antipsychotics together. And I think this is going to be very important because, as we well know, it is not uncommon, as a matter of fact, fairly common, to see patients on more than one antipsychotic for whatever reason. And as I said before, this is a little bit more rational polypharmacy than some of those other combinations that we've seen.
Oh, much more rational, because most of the people Coke and Pepsi and telling them they're actually getting a different beverage.
Yeah.
Where here, we may be doing something postsynaptically, whether with aripiprazole or a D2 antagonist, and now it can work presynaptically to help that if they had insufficient positive symptom control.
And potentially, as we said, M1 could be benefiting some of the other negative cognitive symptoms. What's really exciting to me also about this trial is not only is it efficacious to do this, and these are patients who are not treatment resistant. They've had some kind of inadequate control, some incomplete response, and so we might see efficacy. But I'm really excited, Jonathan, because I know clinicians are going to do it. Our colleagues are going to do this. We're going to have safety data, and that will be really exciting too.
Yeah, I think the point out there is, as we've tried to kind of hopefully educate you a little bit, that this is a novel mechanism which you should try to understand to the best you can how it works, that it's working presynaptically, and it's a muscarinic agonist. This really is a novel idea for managing schizophrenia. It really is a revolution, and I don't use that very often.
Yeah, and you're not prone to hyperbole in my experience.
And so I hope, that having heard this, not only are you excited, but we've also given you some ideas about how these medications work and how you get people on existing treatment who are reasonable candidates, meaning they're not on clozapine, and use these new medications effectively and tolerably.
Yeah, usually when a new antipsychotic comes out, one of the patient types you say to switch for is tolerability or safety, weight, and so on. Here, I think we have a medicine that is very reasonable to switch for those reasons, but may also be very reasonable for efficacy, inadequate efficacy. So one final thing I want to say, Jonathan, is this medication we've been speaking about, the combination of xanomeline and trospium, and as you said, the brand name is Cobenfy, was FDA approved on September 26th. So I know you'll add that to your dates of approval. Should be available, my understanding, Jonathan, is in the pharmacies at the end of October, so before the end of this year. So hopefully clinicians will have the opportunity to try it. And as we've said, there are a number of these drugs in development. We are entering the era of muscarinic agonism, and we will just see how important M1, M4, agonism, PAM, all these things are. And the good news is more options are better for our patients. As I said, the next one in line probably won't be for another couple of years or so. So this is something we'll be rolling out over the next decade or more. Well, Jonathan, as always, I have greatly enjoyed our conversation, and I hope our audience has too. I hope they found this informative. And maybe, it's going to take some time for people to learn this, Jonathan. I think they may have to go over it a few times. I know it took me a few times to really kind of get it, and that's okay. But I hope we've given them this sense of excitement that I know you and I and many of our colleagues feel, and they'll try this in their appropriate patients. So, Jonathan, thank you so much.
My pleasure, and I hope you've all enjoyed this podcast.
Absolutely. So I just want to say, for more of our educational offerings at NEI, please go to our website, which is neiglobal.com. Until next time, this is Dr. Andy Cutler. Thank you.
Thank you for your participation in this CME NEI podcast episode. To receive your certificate of CME credit, please refer to this podcast's description page for a link to print your certificate. This concludes the CME podcast presentation. For more information about NEI and our premier educational content, please visit neiglobal.com.